Hello everyone, welcome back to my channel and let us start with immunology first. I'm gonna go through the first day. The first thing is the immune system organs. We have primary organs, secondary organs. Primary organs are bone marrow and thymus. In B, for B, bone marrow, B cell maturation, immune cell production. T is for thymus and T cell maturation. Next, we have secondary organs, spleen, lymph nodes, tonsils, adenoids, appendix, Peyer's patches. This allows immune cells to interact with antigens. Next, coming with lymph node, a secondary lymphoid organ that has many afferents, one or more efferents. So it is encapsulated with the trabeculae. Functions are non-specific filtration by macrophages, circulation of B and T cells, and immune response activation. Follicle. This is located in the outer part of the cortex. You can see it over here in the image. It's the site of B cell localization and proliferation. The primary follicles are dense, if you can see this one out here, and quiescent. And the secondary have pale center, germinal center, and are active. So this is the germinal center, and they have a mantle zone. So this is a secondary follicle. Okay, next coming to the medulla. In the medulla, we have medullary cords, medullary sinuses. Okay, the cords are the closely packed lymphocytes and plasma cells. So this is a low lymphocyte and plasma cell, sorry. And then medullary sinus, it's the reticular cells and the macrophages. These communicate with the efferent lymphatic. If you can see it here, the medullary sinus is communicating with the efferent lymphatic. So paracortex, we have T cells, region of the cortex between follicles and medulla, contains high endothelial venules through which T and B cells enter from blood. Underdeveloped in patients with DiGeorge syndrome. Paracortex enlarges in extreme cellular immune response, EBV, and other viral infections. Paracortical hyperplasia, lymphadenopathy. Next, we have the lymphatic drainage associations. Lymph node cluster, area of the body drained, and associated pathology. So here we have the submandibular and submental. Um, it's the oral cavity, anterior tongue, and the lower lip. Malignancy and metastasis associated with the oral cavity. Deep cervical, head, neck, oropharynx, upper respiratory tract infection, and infectious mononucleosis. Kawasaki disease, malignancy of the head, neck, oropharynx. And then we have the supraclavicular. Supraclavicular is the right hemothorax for the right side. The left side is the left virchow node, left hemothorax, abdomen, pelvis. Malignancies of the thorax and abdomen. Next we have mediastina, trachea, esophagus. Then hilar is the lungs. These all have like pulmonary tuberculosis if it's the unilateral hilar. Bilateral hilar is sarcoidosis. Then we have lung cancer, granulomatous disease. Coming to the axillary area, we have upper limb, breast, skin above the umbilicus. Then we have epitrochlear, hand, forearm, this secondary syphilis. And then we have celiac, superior mesenteric, inferior mesenteric. Celiac is the liver, stomach, spleen, pancreas, upper duodenum. Superior mesenteric is lower duodenum, jejunum, ileum, colon to splenic flexure. Inferior mesenteric is colon from splenic flexure to upper rectum. All these deal in the mesenteric lymphadenitis, inflammatory bowel disease, celiac disease. Next, we have the Periumbilical system may be Joseph node, abdomen and pelvis in the gastric cancer. Then we have para-aortic, which is the pair of testes, and then ovaries, kidneys, fallopian tubes, fundus of uterus. So any metastasis over there, that's the para-aortic. Okay. Next we have external iliac, body of the uterus, cervix, superior bladder. Internal iliac is the cervix, proximal vagina, corpus cavernosum, prostate, inferior bladder, lower rectum to anal canal, above the pectinate line. Superficial inguinal, we have distal vagina, vulva, scrotum, urethra, anal canal below the pectinate line, skin below the umbilicus except popliteal area. All the sexually transmitted infections, medial foot, leg cellulitis, superficial inguinal. Next we have popliteal, that's the poplateral, dorsolateral foot, posterior calf, lateral foot or leg cellulitis. Right lymphatic duct drains right side of the body above the diaphragm into junction of the right subclavian and internal jugular vein. Thoracic duct drains between below the diaphragm and left thorax and upper limb into the junction of left subclavian and internal jugular veins. Rupture of thoracic duct can cause chylothorax. Next we have the spleen located in the left upper quadrant of the abdomen, anterior lateral to left kidney, protected by the 9 to 11th ribs. Splenic dysfunction that are like post-splenectomy, sickle cell disease, autosplenectomy, decreased IgM, decreased complement activation, decreased C3b opsonization. Thereby, there is increased susceptibility to the capsulated organisms. Okay, post-splenectomy findings, you'll have jolly bodies, nuclear remnants, target cells, thrombocytosis, loss of sequestration on removal, and lymphocytosis, loss of sequestration. Vaccinated patients undergoing splenectomy or with splenic dysfunction against encapsulated organisms, pneumococci, Hib, meningococci. So white pulp is WBC. We have follicle B cells, mantle zone, and germinal center. Then we have the marginal zone, um, periarteriolar lymphoid sheath T cells, capsule trabecular. Red pulp is the RBC, sinusoid, reticular fibrous framework, open circulation, closed circulation, and pulp vein, artery, and vein. Periarteriolar lymphatic sheath contains T cells located within the white pulp. Follicle contains the B cells located within the white pulp. Both T and B are in the white pulp. So red pulp has RBCs. Then we have marginal zone contains macrophages, um, specialized B cells, and then we have site where antigen presenting cells, APCs, capture blood-borne antigens for recognition of the lymphocytes located between red pulp and white pulp. Thymus, it's located in the anterior superior mediastinum. Site of the T cell differentiation and maturation encapsulated. Thymus epithelium is derived from a third pharyngeal pouch endoderm, whereas thymic lymphocytes are of the mesodermal origin. Thymus is derived from the third pharyngeal pouch, which is the endoderm. Thymic lymphocyte is mesoderm. Cortex is dense with immature T cells. Medulla is pale with mature T cells. Hassel's corpuscles containing epithelial reticular cells. Normal neonatal thymus is cile-shaped on chest X-ray. Involutes by age 3 years. T cells is thymus. B cells is bone marrow. Absent thymic shadow or hypoplastic thymus is seen in some immunodeficiencies like SCED and Descharges syndrome. Thymoma, neoplasm of the thymus associated with myasthenia gravis, superior vena cava syndrome, pure red cell aplasia, and Good syndrome. Good syndrome is thymoma with immunodeficiency. deficiency. So you have hypogammaglobulinemia, increased susceptibility to infection. This is a triad. Next, coming to the innate versus adaptive immunity. Okay, innate immunity and adaptive immunity. Let's go through each of them one by one. The innate immunity is neutrophils, macrophages, monocytes, dendritic cells, natural killer cells, lymphoid in origin. And then we have complement, physical epithelial barriers, secreted enzymes. Mechanism, germline encoded. Responses, non-specific, usually occurs from minutes to hours, rapidly, and no memory response. The secreted proteins are lysozymes, complement, C-reactive protein, defensins, and cytokines. Key features in pathogen recognition. Toll-like receptors, pattern recognition receptors that recognize the pathogen-associated molecular patterns and lead to the activation of NF-kappa B. Example of PAMPs, LPS, gram-negative bacteria, flagellin bacteria, and then nucleic acids for viruses. Next, we have adaptive immunity, T cell, B cell, circulating antibodies. Mechanism is VDJ. That's variation through VDJ. Recombination through lymphocyte development. Next, response is highly specific, refined over time. Develops over long periods. Memory response is faster and more robust. Immunoglobulin cytokines. Then we have key features in pathogen recognition. Memory cells, activated B and T cells, subsequent exposure to a previously encountered antigen, stronger, quicker immune response, adaptive immune responses decrease with age, immunosenescence. Next, immune privilege, organs that is brain, eye, placenta, and testes, and tissues where chemical or physical mechanisms limit immune response to foreign antigens to avoid damage that would occur from inflammatory sequelae. A allograft rejection at these sites is less likely. Okay, next we have the major histocompatibility complex 1 and 2. MHC encoded by HLA gene um, presence on the T cells and binds T cell receptors. The toll T cell receptors or TCRs. Okay, MHC1 and MHC2. HLA-A, B, C. That is one loci have one letter. Two is the DPDQDR. Two loci have two letters. For MHC1, it is CD8. 1 into 8 is 8. And two T cell receptor for the binding site. MHC2, T cell receptor, and CD4. 4 into 2 is 8. So CD4. Structure, one long chain and one short chain for 1. Two equal length chains, that is 2 alpha or 2 beta for 2. Expression, all nucleated cells, APCs, platelets except for RBCs is MHC1. Only APCs is for MHC2. Function, present endogenous antigens, example viral or cytosolic proteins to CD8 plus T cytotoxic T cells. Present exogenous antigens, that is bacterial proteins to CD4 plus helper T cells is MHC2. Antigen loading, antigen peptides loaded onto MHC1 in RER after delivery via TAP, transporter associated with antigen processing. Antigen loaded following release of invariant chain in an acidified endosome. For the MHC2, associated proteins are beta 2 microglobulin for MHC1, and then we have the invariant chain for the MHC2. Structure, we have alpha, one long chain and one small chain. Sorry, for MHC1 and two equal size chains for MHC2. HLA subtypes associated with diseases. We have B27, that is psoriatic arthritis, ankylosing spondylitis, IBD, Associated arthritis, reactive arthritis, that is the pair. B57, Abacavir hypersensitivity, DQ2 or DQ8, celiac disease. I ate too much gluten and DQ. So DQ2 and 8, celiac disease, gluten. DR3, sorry, DM type 1, SLE, Graves' disease, Hashimoto's thyroiditis, Edison disease. DM type 1 is HLA3 minus 3 and minus 4. That is 1 plus 3 is 4. So diabetes has 1 and HLA3 and 4. And then SLE, SL3. Okay, DR4 is rheumatoid arthritis. 4 rooms in a wall. Sorry, 4 walls in a room. And then diabetes type 1 and Edison disease. Okay, then we have the functions of natural killer cells and major functions of the B and T cells. Functions of the natural killer cells: lymphocyte, member of the innate system. Perforin and granulozymes are the enzymes they use for apoptosis of virally infected cells and tumor cells. Activities enhanced by IL-2, 12, interferon alpha, interferon beta. Induced to kill when exposed to a non-specific activation signal on target cell and or to an absence of an inhibitory signal such as an MHC on 1 on target cell surface. Also kills via antibody-dependent cell-mediated cytotoxicity. CD16 binds Fc region of the bound immunoglobulin G, activating the NK cells. Major functions of the B and T cells. B cells, humoral immunity, recognize and present antigen, undergo somatic hypermutation to optimize antigen specificity, produce antibody, differentiate into plasma cells to secrete specific immunoglobulins, maintain immunologic memory, memory B cells persist and accelerate future response to antigen. T cells, cell mediated immunity, CD4 positive T cells help B cells make antibody and produce cytokines to recruit phagocytes and activate other leukocytes. CD8 positive T cells directly kill virus infected and tumor cells via perforin and granzyme, similar to NK cells. Type 4 hypersensitivity reaction and acute and chronic cellular organ rejection. Differentiation of the T cells. Bone marrow, thymus, lymph node, and peripheral blood. So, starting from bone marrow, we have T cell precursor. In the thymus, it undergoes this. It is CD4 positive and CD8 positive. So, positive selection. So, CD8 positive becomes cytotoxic, CD4 becomes helper. Negative selection in the medulla, positive in the cortex and negative in the medulla. Next lymph node, you have interferon gamma, IL-12 positive, so and inhibitors are IL-4, IL-10 for Th1, interferon gamma and IL-2 is what is secreted, and this activates the macrophages and cytotoxic T cells. Gamma and 12 are they and then inhibited by 4 and 10. So gamma and 2 is what is secreted and activates macrophages and cytotoxic T cells. IL-2 and IL-4 and inhibitory is again here gamma, interferon gamma. So this is Th2, 2,4 for Th2. So IL-4, 5, 6, IL-10 and IL-13 activate eosinophils, increased IgE. Next we have for the TGF beta, IL-1 and IL-6 Interferon gamma and IL-4 is inhibitory. Th17. So they form the IL-17 and IL-21. IL-22 is secreted. This induces neutrophilic infiltration. TGF-beta and IL-2 inhibited by IL-6 Treg. TGF-beta, IL-10 and IL-35 prevent autoimmunity, maintains the tolerance. Positive selection. Thymic cortex keeps T cells that recognize self-peptides to allow for cooperation and immune responses. Double positive thymocytes expressing TCRs that recognize self-peptide MHC complexes receive a survival signal. Negative selection. Thymic medulla removes T cells that bind too strongly to the self-peptides. Thymocytes expressing TCRs with high affinity for self-antigens undergo apoptosis to or becomes regulatory T cells. The autoimmune regulator AIRE protein derives negative selection and deficiency leads to autoimmune polyendocrine syndrome, chronic mucocutaneous candidiasis, hypoparathyroidism, adrenal insufficiency, recurrent candida infection. Without air, your body will char. CHAR, chronic mucocutaneous candidiasis. Then we have hypoparathyroidism, adrenal insufficiency, and recurrent candida infections. Macrophages, lymphocyte interaction, Th1 cells secrete interferon gamma, which enhances the ability of monocytes and macrophages to kill microbes they ingest. This function is also enhanced by interaction of T cells, CD40 ligand with CD40 on macrophages. Macrophages also activate lymphocytes via antigen presentation. Cytotoxic T cells kill virus-infected neoplastic and donor graft cells by introducing apoptosis. Release cytotoxic granules containing preformed proteins, perforin, granzyme B. Cytotoxic T cells have CD8, which bind to MHC1 on virus-infected cells. Regulatory T cells help maintain specific immune tolerance by suppressing CD4 positive, CD8 positive T cell effector function, identified by the expression of CD3, CD4, CD25, and FOXP3. Activated regulatory T cells, Tregs, produce anti-inflammatory cytokines IL-10, TGF-beta, IPEX, that is the immune dysregulation, polyendocrinopathy, enteropathy, and X-linked syndrome, the genetic deficiency of FOXP3, thereby autoimmunity, characterized by enteropathy, endocrinopathy, nail dystrophy, dermatitis, and or autoimmune dermatological conditions associated with diabetes in male infants. T and B cell activation, APCs. So here we have this is a bit in depth. So we'll do this in the next video. Thank you for watching.